Well, good afternoon. Good afternoon, dear colleagues. My name is Máximo Bernabeu-Wittel, and it is a pleasure for me to share with you this new webinar, this autumn webinar of the European Federation of Internal Medicine, in which we will deal with a very common and emergent syndrome, which is sarcopenia in our patients with multimorbidity. There are two experts who are accompanying me in this webinar, and let me introduce both of them to you. First, expert is Samuel García Rubio. He is internist and works in the University Hospital Marqués de Valdecilla in Spain, and he will talk us about the identification and diagnosis of sarcopenia in patients with multimorbidity. And the second one is also an expert in this field, and is Jūlija Voicehovska. She is also a member of EFIM Multimorbidity Working Group, a very active member, and she will talk us about a new paradigm, a new syndrome, and its management, which is osteosarcopenia. She works in internal medicine department, specifically in the nephrology and renal replacement therapy clinics in Riga, Latvia. And I want to show my gratitude to both of them. Also, I want to thank EFIM Academy for its technical support. And of course, I want to thank to all attendants to this webinar and meeting. So if you agree, let's first listen to both presentations, and then we could gather all the questions together for a final debate and conversation that could last a few minutes. For those attending who wish to make a comment or ask any question, please do via the chat function available on your screens in the Zoom application. So if you agree, we can start to our first lecture. Samuel.
Okay, thank you, Máximo. It's an absolute pleasure to be here with you to talk about a very, as Máximo said, very prevalent healthcare issue, and the problems or main reflections about the identification and diagnosis, especially in patients with multimorbidity. Well, first, I will try to answer these questions. No? Why should we care about sarcopenia? Is sarcopenia even a disease, or is it a condition? Is it a risk factor? What is this? When should we suspect sarcopenia, and on which individuals should we test them? And how is it confirmed? And then finally, some take-home points to end this presentation. Well, sarcopenia is prevalent, but in community dwelling elders, at least here in Spain, that we have studies, prevalence studies, it's about 1 out of 5 patients that we can see in the community. Well, the most important thing is that the prevalence of severe sarcopenia is about 5%. Sarcopenia, as I think Dr. Voicehovska is going to say, is a preventable disease, and we can treat it. What about the patients we see in the wards in the hospital? Admitted patients are about 2.5 out of 5 patients have sarcopenia. And it's even more prevalent in the residential facilities, almost 3.5 out of 5. And regardless the method we use to diagnose them. Whether we use the first consensus on sarcopenia diagnosis or the second one, the prevalence is very, very high in the people living in residential facilities. What about the polypathological patients? The patients living with multimorbidity, the prevalence is almost the same as elder in the community. This is a study from Spain. I have to credit Maximo for this study. And the most relevant thing is almost 1 out of 5 patients has moderate or severe sarcopenia. And this entails a risk for mortality and readmission that are endpoints, relevant endpoints in our healthcare. But what about the community-dwelling polypathological patients? The prevalence is not very well known. It ranges between 5% to 25% of the multimorbidity patients in the community. But strikingly, we don't know. We have scarce data about young polypathological patients. It is estimated in less than 5% of young polypathological patients that have sarcopenia. Well, sarcopenia is indeed a disease. We have a code since 2016. Sorry. It is this code, and it's under the family of diseases of the musculoskeletal system. We expected this to rise the prevalence of the sarcopenia diagnosis, but the reality is that we have to conduct prevalence studies to know how much sarcopenia do we have in our communities, in our hospitals, or in our residential facilities. And this may be because and this is a first reflection, sarcopenia is not that straightforward to diagnose. And we may not be so much sensitized or conscious about the importance of this disease. The diagnosis is a construct. It is by consensus criteria. Experts around the world met and decide which patients should be diagnosed with sarcopenia. And we have two different scenarios. We can make a guideline for all the patients, all elder patients, all the patients in the community, or we can have guidelines disease specific or population specific. For example, people with heart diseases or with COPD can be a different kind of population, and both approaches has pros and cons. I think that the most powerful thing we have with international worldwide guidelines is that we have a consistency and we can compare each other regardless the disease the patient have. And more importantly, the patients we attend now tend to have more than one disease, so probably they don't fit in either population-specific guideline. Well, this is the way we diagnose here in Europe the sarcopenia. For time constraints matter, I will stop in the diagnosis. I will not address the severity of the sarcopenia. And I want to point here when we are certain enough to say that a patient has probable sarcopenia, we need to treat them and we need to change the management that Jūlija will tell you later. And another point that I will highlight here is that for confirmation, we need just muscle quantity or quality, and this may be addressed, as we may see later, by some kind of different techniques. Well, sarcopenia is about function, and it's about quantity of the skeletal muscle mass. We agree that patients 65 years and older should be screened, especially if they have these conditions: fall or a recent admission, rapid functional decline, unintentional weight loss, people who smoke, and specific diseases like heart disease, kidney disease, COPD, and so on. And the second reflection is if people elder than 65-year-old with a specific disease should be screening, this is probably all the patients we see in the polypathological clinic. And shouldn't we perhaps, or aren't we screening all of them? Well, can we screen them? Well, the validated or the clinical validated method is the SARC-F scale, and with 4 or more points, you qualify for continuing the evaluation. When we address this thing, if we perhaps we don't use the SARC-F questionnaire to assess for sarcopenia here in Spain, we know that overlapping the two models, using or not using the SARC-F questionnaire, when we use the SARC-F questionnaire, we diagnose less proportion of sarcopenic patients, and the sensitivity is not great. It's poor. It's ranging from 20 to 40%, and the positive and the negative predictive value depend a lot on the prevalence. And if we screen people in a residential facility, we may have false negatives, and if we screen young polypathological patients in the community, we may have false positive. It's a question of knowing which population or which prevalence we expect to be screened. How does the procedure continue? We need to assess for the function, either with a hand grip strength with a dynamometer or the chair stand test. And of note, the chair stand test is validated in a cohort of people with a mean age of 73 years. And what about the young polypathological patients? The cutoff points for the hand grip strength are for older people. We need probably community-based cutoff points, especially for young people with living with multimorbidity. Well, and how it is confirmed? We have a wide range of techniques from the dual X-ray absorptiometry, or the DXA or DEXA, the bioimpedanciometry, the MRI, and the CT scan. Each one of them has pros and cons, as we see later. And then, in the recent years, out of what is included in the guidelines, or in the consensus, the ultrasound arises as a potential tool for confirming sarcopenia. Well, the DEXA is the one recommended by consensus. It's the most solid recommendation, but not everyone has a machine. The machine is not portable. You have to get the patient to a specific room with techniques to get this scan done. And it estimates, as we may see later, the muscle mass. The technique doesn't measure directly the muscle mass. It is quite expensive. It's not the most expensive test we can order in the hospital, but probably it's overcome by the bioimpedanciometry that is cheaper, it's quicker to get the measure, and it's portable. This is a very important thing if you work in the ICU. The problem is that it's not quite accessible. Not every internal medicine department has this equipment, and it also estimates the muscle mass. It's cheaper than DEXA, but it's not free. The CT scan is very precise. It's available in certain patients that you have a thoracopelvic CT scan done for any other reason, and we can talk to the radiologist to estimate the muscle mass by measuring the psoas muscle. It's not quite accessible since we don't order a CT scan just to confirm the sarcopenia. This wouldn't be appropriate because it has ionizing radiation. It may be dangerous for the patient. It's more expensive than the DEXA and has some troubles differentiating muscles with or without myosteatosis, with an infiltration of fat tissue in the inside of the muscle. And lastly, the MRI is the best resolution for both quantity and quality of the muscle mass, but it's not accessible. It's a test that takes a lot of time to get done and it's a lot of money to invest in just confirming. And as we said previously, in the criteria, in the consensus criteria, if you are just suspecting that the sarcopenia is probable, you can treat it. Why does the bioimpedantiometry and the DEXA estimates the muscle mass? Well, this is the 5-compartment model of the body composition, and the skeletal muscle mass is in the lean soft tissue compartment. That is what the DEXA and the bioimpedantiometry measures, and it estimates by some kind of mathematical formula in standardized conditions of hydration, of body weight and surface. You can estimate the skeletal muscle mass. That is maybe biased in admitted patients in which the water compartment may be quite liable. Well, the ultrasound, CT scan, and MRI address directly the skeletal mass compartment. What about the ultrasound? Well, it's cheap, quick, portable, accessible, it's for everyone, and could assess the myosteatosis, but is not yet standardized. It has a good sensitivity, but a poor specificity. And if we translate what we do in diseases like the HIV, we need a very sensitive first step test and then a good specificity second step test, like the Western blot. For example, we are doing SARC-F as the first step that is not very good in sensitivity, and then we can use another test that is very good in sensitivity, but as we see in this study in Spain with a lot of subjects, especially in women, the specificity is not very good. The area under the curve is very, very low in the women cohort. And probably we need to refine and conduct further studies to know what is the role of the ultrasound in this diagnosis. Well, sarcopenia, and to end this presentation, is prevalent, it's important, and it's a huge cost in our healthcare system. We have scarce data for polypathological patients, and especially in particular those that are less than 65 years old. It's not a straightforward diagnosis. It is a multiple-step diagnosis and may be time-consuming for our outpatient clinic or a busy medical world. Well, we need to simplify using available tools. Maybe not all of us has a dynamometer, but we have chairs or in our wards and in our outpatient clinic. So use them to diagnose. And of course, if it is probable, just treat it and reserve the confirmations for those cases that you are not sure or quite sure that maybe a bias because the patient may have osteoarthritis in the hand and cannot do the dynamometry, or if the patient have knee osteoarthritis and cannot stand as quick as we expected. And then if you need to confirm, use whichever accessible tool you have, because it is not reasonable to refer patient to another clinic just to make a DEXA or to use a CT scan just for confirmation purposes. And without further to say, I end this presentation and I think it's Voicehovska, Dr. Voicehovska turn. Thank you very much.
Thank you very much, Samuel, for your brilliant and thorough presentation and lecture. Let's go to our second expert, Jūlija. She will talk to us about this new syndrome, osteosarcopenia.
So, hello to everybody. Thank you so much for inviting me, and I'm happy to share with you my interest about osteosarcopenia. And today we are talking about this phenomena, about this concept within context of multimorbidity. Where interactions between chronic diseases significantly accelerate decline. So this is my disclosure. There are no conflicts of interest relevant to today's material. Recommendations are grounded in current evidence and guidelines. So my lecture moves from definition and mechanisms to evidence, diagnostics, and practical managements. So as we know that about regarding definition, so I just repeat, it is the coexistence of sarcopenia and osteoporosis producing synergistic decline. Combined, they significantly increase fracture and mortality risks. Such overlap is common in older adults with multimorbidity. So talking about pathophysiological mechanisms, bone and muscle are interconnected via mechanical, metabolic, endocrine pathways. Multimorbidity, as we know, amplifies inflammation, also hormonal decline and physical inactivity. Insulin resistance further impairs anabolic responses. So these factors common in multimorbid patients accelerate combined bone and muscle loss. So, and the result is a self-reinforcing downward spiral typical for multimorbid patients, predisposing risk of osteosarcopenia. So, when analyzing evidence available from clinical studies, so one may conclude about actually quite well done available evidence. Meta-analyses provide strong data on prevalence and mortality risk. Cohort studies confirm clinical impact in hospital and geriatric settings. There are mechanistic research available that explain why multimorbidity accelerates decline. So together these data form a robust evidence base for intervention. So thus meta-analysis, there are meta-analysis data available showing that osteosarcopenia markedly increases mortality and is widely prevalent. Around about 20% of older adults that are affected, with higher rates in frail populations. These findings underscore urgency. High quality evidence supports routine screening. So encourages, I would say, routine screening. Early recognition is critical for risk modification. So clinical cohorts demonstrate that highest mortality among osteosarcopenic patients, particularly in inpatient settings. This highlights the need for identification during hospitalization. Mechanistic data validate biological plausibility. Evidence from multiple domains aligns consistently. So this supports confidence in targeted interventions. As I mentioned before, multimorbidity intensifies osteosarcopenia through cumulative inflammation, endocrine failure, malnutrition, and inactivity. Physiological reserve is diminished, thus chronic diseases interact synergistically. Heart failure limits activity, COPD reduces oxygenation, chronic kidney disease restricts protein intake. Each comorbidity adds vulnerability. This complexity increases but also clarifies the need for multidisciplinary care. So, in general, in multimorbidity, traditional cut-offs might not reflect true physiology. So, for example, edema, neuropathy, pain, fatigue might distort test results. So, like COPD and heart failure limit performance measures. So, edema might affect both DEXA and bioimpedance results. This necessitates interpretation rather than rigid thresholds. Yeah? So diagnostic flexibility is essential in complex older adults. So, and red flags for such patient cases should include patients with rapid functional decline, unexplained vitamin deficiency, and weight loss above 5% in 6 months. So, talking about nutritional vulnerability, malnutrition is both a cause and consequence of osteosarcopenia. Chronic diseases might reduce protein intake, like for example, chronic kidney disease complicates protein optimization. Micronutrition deficiency are common and clinically relevant. So addressing nutrition early is essential for recovery and progression control, and at the same time, so red flags within context of malnutrition include these signs of cachexia, as I mentioned already, this micronutrition deficiency and inability to reach goal of protein supplementation. So also regarding exercise limitation, so standard programs are often unrealistic for frail older adults. Symptoms such as dyspnoea, pain, fatigue impair adherence. Resistance training remains effective but requires modification, adjustment to patient capability. So again, these red flags that should be considered, taken into account, these are patients experiencing dyspnoea, orthostatic hypotension, and with past history of recent fractures. So pharmacological challenges in multimorbid patients when medication choices should consider comorbidity pattern, like as renal impairment might restrict bisphosphonate options. Denosumab might require correction of hypocalcemia. Polypharmacy might increase fall risk, like taking medications affecting cerebral flow, for example. Yeah. So pharmacological therapy must be individualized for safety and efficacy. So red flags within context of pharmacological choice should include kidney function, calcium level, and central nervous system affecting drugs to reduce risk of fainting, loss of consciousness, risk of falls. So there are so-called high-risk phenotypes, those who prone to osteosarcopenia. So, and you know that frailty frequently accompanies osteosarcopenia and worsens outcomes. So cognitive impairment, social vulnerability, reduce adherence, and again provoke this risk. So frailty increases sensitivity to stressors. Comprehensive geriatric assessment might improve. Treatment planning should improve. And multidisciplinary care strongly recommended. Yes, so again, within such context, the right flags that should be considered. This is past history of such symptoms consistent with frailty. So the strongest data support multimodal interventions. So incorporating resistance training, protein intake appropriate, and pharmacologic osteoporosis treatment. Vitamin D provides benefit when deficient. Exercise and nutrition magnify each other's effects. Pharmacological treatment protects bone, but cannot restore function alone. So again, integrated approach is essential. Treatment options include biphosphonates, denosumab, teriparatide, and romosozumab. Renal function and calcium levels determine safe use. Anabolic therapy is beneficial for high-risk patients, and treatment balances efficacy with frailty and tolerance. So non-pharmacological interventions include physical training, first of all, resistance training that provides direct anabolic stimulation to muscle and bone. Balance exercises reduce fall risk. Adequate protein intake is crucial. Fall prevention strategies, including medication review, are essential. So these interventions remain effective. Also, I would like to focus your attention on this focus population. So who to screen? These are older adults with functional decline, frailty, weight loss, recent hospitalization. Chronic conditions such as diabetes, chronic kidney disease, COPD, inflammatory diseases increase risk. Prior fractures strongly indicate vulnerability. Early detection improves prognosis, so screening is efficient and clinically meaningful. So Structural approach offers screening, correction of nutrition, initiation of resistance training, treatment of osteoporosis, individualization to comorbidities, and reassessment every 6 months. So such sequence ensures comprehensive care, and it fits naturally into clinical workflow. Reassessment allows monitoring progress and optimizing treatment. Continuity is a key. So, best evidence tips recommend to consider osteosarcopenia as a high-risk phenotype requiring early combined interventions. We are advised to screen hospitalized patients proactively, always interpreting diagnostic tests with clinical judgment in multimorbidity. So, summarizing, osteosarcopenia in multimorbidity is common, clinically significant, actionable. Early recognition and multi-domain intervention improve outcomes. Diagnostics require contextual, individualized interpretation. Combined exercise, nutrition, and pharmacological treatment is most effective. So collaborative interdisciplinary care is essential. So thank you so much for your attention, and I'm ready to answer the questions, if any. Thank you.
Thank you very much, Jūlija, for your outstanding review and lecture. And thank you for letting us the time 20 minutes. We have 20 minutes for discussion. And this is, I want to show my gratitude to both of you for your choosing wisely your time of lecture. We have a pair of questions from the audience. I remember to all assistants that you can answer your questions in the answer and responses tip in the bottom of your screens. Mehab Kakar, he has a question to Samuel. I read it to you, Samuel. Do you think that the increase in physical inactivity after the pandemic has raised the risk of sarcopenia in young people? How should sarcopenia be screened in young and otherwise healthy individuals? And do you have an assessment scale for this purpose in these populations?
Nice, for sure. It has done. Not only the advent of the COVID-19 pandemic, but also the advent of the GLP-1 analogs that are increasingly being used. Both GLP-1 and ESLG2 inhibitors pose a risk of diminish the muscle mass. So we are nowadays seeing more and more young patients with sarcopenia. The problem is that we don't have cutoff points. There are some population-based tables to look for, especially dynamometry. We have here in the north of Spain, in the Basque Country, and I believe there are probably others for European country that may reflect that the patient is weak at least, that the muscle is not functioning well. But I grant a lot of credit to the patient that feels weak and at least a subjective functional decline referred from the young patients who arise the question that if the muscle mass is okay or not. And probably in these patients, the muscle quantity is not very good predictor, and you need to assess the muscle quality. Ultrasound is not just the B mode that you can see fat infiltrating the muscle. You can see a very, very, very hyperechogenic, very bright muscle that leads to relevant myosteatosis suspicion. But you can use advanced mode like elastography, the shear wave elastography that may at least point to low quality muscle mass, and if you suspect it, you need to treat it. And exercise, as my colleagues would agree, is the cornerstone of the treatment of sarcopenia.
Thank you very much, Samuel. There is another question. This one for Jūlija, from José Luis Hernández. He has written a comment and a question considering the interplay between sarcopenia, osteosarcopenia, multimorbidity, and frailty, and the limited evidence on efficacy of single intervention in complex older patients. Should our current approach shift from disease-specific management to a patient-centered muscle-preserving strategy? And what are the practical barriers to implementing such a paradigm in routine clinical practice?
Thank you for the question. Actually, question emphasizes the cornerstone of the problem. Indeed, we should adjust our treatment strategy to a multimorbid patient when focusing on osteosarcopenia. But unfortunately, the majority of guidelines are adjusted to particular pathology. Yes, so we have we are advised to treat monopathology. Yes, so by majority of guidelines. Yes, so this is why I believe that now we, as health professionals and researchers, we should focus our attention on multimorbid patients, and we need to deal with the studies focused on this population and accordingly adjusting or developing guidelines that are suitable for multimorbid patients.
Thank you very much, Jūlija. I have two additional questions to both of you. First of one is for Samuel. Samuel, what do you think about this thinking, or what the thought many of us are having in last times? We have these clinimetric screening tools that are advised in most consensus documents to screen for sarcopenia. But I guess if these clinimetric tools are really necessary, or should be directly perform handheld dynamometry or any muscle strength test in clinical practice as screening tool. I mean, they are safe and accessible procedures. And for instance, when hand grip strength is affected, the likelihood of suffering this sarcopenia syndrome is really high and increases drastically. So I don't know if we could jump over the classical clinimetric tools as a first step screening for sarcopenia. What do you think about it?
Thank you for the question. I guess it depends. It depends on the population you are dealing with. If you are in a high prevalent setting, like a residential facility, there is no need of a screening with a questionnaire. Almost a wide range of patients will have relevant sarcopenia. I think the weakness of the SARC-F questionnaire is the sensitivity. We need a very sensitivity test to address in a population in which the prevalence maybe not that high, maybe in the community or in the hospital wards the prevalence is different, and we must behave differently and according to the prevalence. Myself, I must confess that I don't use the SARC-F questionnaire because my clinical practice is in the prevalence of multimorbidity or advanced age with high risk profile for this disease is almost 80% of the people I attend. So I go directly with hand dynamometry, and if I suspect that hand dynamometry is not reliable, I do chest stand test.
Thank you very much. And for Jūlija, what about exercise programs, exercise in older and elderly adults? We have really difficulties, not only difficulties in our competences in prescribing exercise, which should be, I think, taught in medicine schools and in residency programs, but we have also difficulties in following the experts' recommendations for our daily patients. Because if we follow these recommendations, all our elderly people should really be most time of their days in a training center. So, what if we have to choose a really efficacious exercise? What should we prioritize? Strength performance, aerobics exercise, balance performance, mixed intensity, high intensity routines for our elderly people? What do you think about selecting the most useful type of exercise for our osteosarcopenic elderly patients?
Thank you for the question. So it is pretty practical question. What would we recommend to our patients? So in general, mixed high intensity routines are not appropriate for frail patients due to safety concerns, orthostatic symptoms, cardiac limitations, high fatigue burden. Yeah, so this is about high intensity routines. About aerobic exercise, these are beneficial for cardiovascular health and should be included, but at low to moderate intensity. But evidence says that indeed strength resistance training should remain their primary focus, since it is supported by the evidence as improving muscle mass, muscle strength, mobility, and reducing falls. So this resistance training includes low intensity, progressive resistant training using elastic bands, body weight, light weights, depending on tolerance. This is.
Thank you very much. This answer also answers another question from Jose Luis, and he asked about integrated bone muscle preservation strategy. It's clear that If we work with muscles, we are working with bones, and this strategy should be integrated in future. Bone is so important for muscles as muscles for bones. And the typical example is the beneficial effect of vitamin D, both to muscles and to bones. Thank you, Jūlija. I have another question to Samuel. This is my second question, and is what is the future, the real future of ultrasound in the assessment of skeletal muscle mass as confirmatory test? Because we are seeing consensus after consensus, guidelines after guidelines of sarcopenia and osteosarcopenia, and they put always the ultrasound as promising technique, but none of them has already recommended it for clinical practice. Do we have future with ultrasound in the confirmation of sarcopenia or not? Samuel, what is your opinion as expert?
Indeed, ultrasound is the long-standing promising of the diagnosis of sarcopenia because of the price and the portability. But as all ultrasound techniques is quite operator dependent and machine dependent also. The last years, there are a few promising studies about artificial intelligence in interpreting not quite the quantity of the muscle, but the quality, the histograms of the brightness of the muscle reflect the quality. The more bright, the lesser quality. And as operators, this is almost subjective. We can there is a low inter-rater agreement when we see muscle brightness or we suspect the presence of sarcopenia. But with machine learning algorithms, we can improve the sensitivity and the reproducibility of this test. Probably the future is not whether we use or not the ultrasound, but who uses the ultrasound. And we need to take into account that if we, as a hospitalist, myself, diagnose sarcopenia, it's probably too late. Maybe this must be, and the osteosarcopenia diagnosed in the primary care, in the first line of the healthcare system, and then complex cases must be referred. But if we treat patients in the pre-symptomatic stages of both sarcopenia and osteoporosis, we gain avoiding adverse clinical events.
All right. Thank you very much, Samuel. And my second question to Jūlija is in line with a question of one of our attendants from Sheikh Shafi Mamodelabus. I wanted to ask you, Jūlija, there are lots of recommendations regarding nutritional supplements, nutraceuticals, which are advocated to be beneficial for our sarcopenic and osteosarcopenic patients. So Sheikh Shafi asked us what are the most promising emerging therapies that specifically target the dysfunctional crosstalk between muscle and bone. And my additional question is, if you had to choose 2 or 3 compounds with really evidence-based benefit in patients with osteosarcopenia, which of them would you choose, Jūlija?
So thank you for the question. When revising these supplements, first of all, when revising the supplements, we should consider general condition and individual profile of the patient. I again remind about renal function. Yes, so and probably reduced glomerular filtration rate that strongly limits use of particular supplementation. So this is why we should consider three goals. Yes, so this is protein supplementation. This is vitamin D. Yes, so and about optional third. Yeah, so from supplements, there are data about creatine monohydrate, which is considered safe, well studied, and which is synergistic with resistance training. But evidence is stronger in non-frail older adults. Yes, so also essential amino acids from this range of supplementation that might improve muscle protein synthesis, especially leucine, and this also might enhance the effect of resistant training. Yes, so however, talking about improvement of bone muscle mechanism. Yes, so management should focus on this crosstalk, organ specific, from organ specific treatment to this crosstalk between bones and muscles, since this crosstalk is one of cornerstones of osteosarcopenia. Yeah, so this is why medications that might affect this crosstalk and improve bone metabolism. So these are considered, and in my presentation, so I mentioned these medications. So that might be used from this domalizumab and other ones.
Jūlija, thank you very much for your advices. So protein supplementation, vitamin D, and thank you for your bravery in recommending creatine for certain circumstances to sarcopenic patients. We can close the webinar with these last two questions from an attendant. His or she is anonymous attendant and is asking us regarding specific conditions and polypharmacy, the role of polypharmacy contributing to sarcopenia in patients with Parkinson's disease, which I think is very clear, this interaction, and a particular question regarding sarcopenia and osteosarcopenia and fibromyalgia. If any of you want to answer to these specific questions.
Well, first of all, Parkinson's disease is not just about the medication you use in Parkinson. People that suffer from Parkinson's disease are older and might have another comorbidities that you need to treat, and you need to be quite granular on which treatment is more convenient for the patient. Because if, for example, has diabetes, the oral antidiabetics are medication that may promote sarcopenia, and insulin is an anabolic agent. You can consider to switch at least till the condition or the sarcopenia is resolved. And then Parkinson's disease also have the swallowing problem. You may have a very tough problem with the patient to introduce a quality diet if the texture of the meals need to be modified, and probably diet counseling is advisable in this patient, and probably oral supplementation if it may be in risk of malnutrition to ensure protein intake.
Thank you. Thank you very much, Samuel. And regarding fibromyalgia, I think fibromyalgia is a frequent condition, but it's a condition typically from younger ages and mainly affects women. So the pathophysiological mechanisms of muscular the acconditionation are not similar to classical primary sarcopenia due to aging processes. So I don't know if we should establish the same recommendations to patients with fibromyalgia and muscular weakness, and they probably need specifically recommendations based on exercise programs more than nutritional assessment or even drugs. I don't know if I have answered your question regarding this specific issue of fibromyalgia. So any other questions from the audience? If not, we are at 6 p.m. o'clock. The webinar has lasted exactly 1 hour as predicted. I want to thank both of the experts for their outstanding lectures and for their brilliant comments and answer to the questions of the audience. And thank you very much to all colleagues who are connected to us from many countries of Europe and of the Mediterranean basin. And I wish you a good time and a nice afternoon this day of our webinar. Best regards.
Thank you.
Thank you very much.